Okay, so we're going to talk about the eye stent, and that's a 6-page document from Health Quality Council, and it's the summary version. The actual version, I think, is about 168 pages, so very extensive, and this is why they have trouble doing a lot of them, because it's a lot of work to do a proper health technology assessment. Anyway, you've got the summary, so that's what we're going to use. But before we get in there, I want to give you a quick briefing on glaucoma and then define what the heck an eye stent is. So the first, oh shoot, no, I didn't test this video, so I hope it works. Ah, damn it. I am so sorry. Oh shoot. Sorry, give me just one sec here.
Sorry, Mark, I was just saying, I just realized I was muted. You can also share, like if you play the video on your computer, and you can also share your screen, I believe. That's another way you could do it.
Yeah, I don't have the link.
Oh, okay.
Oh crap. Now I got to figure out where the hell.
Is it something on YouTube?
It might be, but I actually have a, oh, I'm so sorry. I should have looked at this before.
It's okay.
All right, I think what I'll do. All right, so while my system is searching for the video, I'm going to just walk through quickly glaucoma treatment. So glaucoma is pressure in the eye, high pressure in the eye, and the high pressure can damage the eye, and it can cause blindness. And it's one of the leading causes of blindness in older people. And there are a number of things you can do to lower the pressure in the eye. The first thing you can do, as you see here, is prescription eye drops for glaucoma. They reduce the eye pressure. Most of these are paid for by the government. Relatively low cost. There's some inconvenience. There are side effects. Sometimes it burns the eyes, and it's a pain to take drops a couple of times a day. So that's one option. Also, there are laser treatments. Laser surgery can help eliminate the need for glaucoma eye drops. However, in many cases, it'll help, but patients will continue to need to take eye drops. You get a high intensity beam of light. It's a laser, and it goes into the trabecular meshwork of inside your eye, and it helps increase the drainage. So there's inflow and outflow constantly in the eye, and if you increase the outflow, obviously you're gonna lower the pressure. It's reimbursed by most insurance companies, but not governments. And then there's this new thing called micro-invasive glaucoma surgery, or MIGS. Eye stent is one of the examples of it, and it is it's the smallest medical implant device, and it's designed to restore the natural ability to drain the fluid. So again, it works on increasing the drainage, and it's implanted at the same time as cataract surgery, or can be a standalone procedure. So cataracts are very commonly very common in the elderly, and so they get cataract surgery. They get that old lens taken out, the foggy one. They get the new one in. Oftentimes, they will do this glaucoma piece at the same time. This is oopsie. So this is the eye stent. I'm not sure why the picture is a bit blown up there, but let me just Screen share. All right. All right, I'm sharing again. Some of the picture got sent up. So you can see how small the iStent is. It's tiny. And a company called Glaukos is the group that has this iStent. So that's the long and the short of it. Let me just see if I have been able to find the video. Nope, it's not on my. Nope, that's not what I'm looking for. Okay, that's all right. The video, it just gives you a quick snapshot on glaucoma and basically says it affects a lot of elderly people. It's about eye pressure in the eye. It's like a bicycle tire, right? You get too much pressure, this causes a problem. In this case, it causes blindness, and so you want to lower the eye pressure. So we can dispense with a video. So then let's go to the case study questions. Now, this is a good example because we've got something which is innovative, but it does cost more. So we got to figure out that cost effectiveness. And so the first thing I'd like you guys to do, and you're going to be broken up into groups. Zoom groups, and you can discuss this. I'll jump around from group to group to guide you or talk to you or answer questions. But the first question is, where does this fit into the matrix? I will put maybe I'll put the matrix up on the slide so you guys can come back in the room if you want to look at it. But you'll recall it's the cost versus the effectiveness. So where does it sit on that matrix? What's the impact to your stakeholder? What are the key messages to the stakeholders? Who are your stakeholders? I think should be, I don't have that here. What is the impact on your stakeholder? Who are the stakeholders? I think that's sort of a key question I should have here. And then what are the challenges in getting your stakeholder to take the desired action? So key questions really is number one, where does it fit in the matrix? Number two, who are the stakeholders? And then number three, what is the impact? If you focus on that, then I think we'll have an interesting discussion. So what we'll do is we'll go out into the breakout rooms for probably 20 or 25 minutes. I'll sort of gauge it a little bit, and then we can reconvene as a group, and we can talk about it as a group.
Sounds great, Mark. So I can break people into groups right now. So we have about 22 people. So yeah, 5 groups would 5 breakout rooms would have 4 to 5 participants per room. So are you okay with that?
Yeah, that works well. Yeah.
Okay. Yeah. So I'm not going to include you, so you can,
jump around. Yeah. Okay.
Okay. So rooms are now being created.
Okay. Is everybody back?
I think so. Yeah, everyone should be here.
All right. Now I don't know if we had there were room numbers, but I don't know if you guys know what your rooms were. So why don't we? Who wants to go first?
I can go, Mark.
Stephanie, Eve, do you want to go?
Yeah, actually, I would. Thanks. So we We structured ours a little bit differently. We ended up coming up with 2 separate charts, and we did it based on no cataract surgery and with cataract surgery.
Mm-hmm.
So you're gonna have to deal with a little bit of messy writing, but essentially the first one, so they're all the same effective, they're stacked on top of each other. And so with no cataract surgery, we rated drops as the most costful, followed by the eye stent, followed by that filtration surgery. And so our recommendation would be filtration surgery if you're not doing any cataracts. But with cataracts, drops were the most expensive, followed by filtration, which was then recommended with that eye stent. So that's kind of how we broke it down. All are equally impactful, but the cost differs based on the circumstance. And then we broke down our stakeholders into patients. So patients.
Let's just pause there, because let's talk about that first question. So so we've got 2 different dynamics here. So I'm just going to bring up the can you guys see my screen?
Mm-hmm.
Okay. All right. So this is the cost effective, not cost effective slide. So let's just walk it back. So where did Stephanie, where did you see? Let's start with not involving cataract surgery. What quadrant did it end up in?
So essentially they're all stacked vertically on each other. So the highest one in terms of cost was the drops. So that would be in position number 1.
But no. So what we're looking at here is the eye stent itself. So
that would be the most effective. So it'd be number 4.
So this number 4 is it's less expensive and more effective.
So the eye stent is in the middle, so it'd be halfway through that 4.
So it'd be somewhere in here, but that is that with cataract surgery or without cataract surgery?
So with no cataract surgery, eye stent would be in position 3. Or sorry, no, it would be more expensive and the same effectiveness. So it'd be in position 1.
Somewhere in here, 1 or 2.
Mm-hmm.
Definitely more expensive. So it's above the line and somewhere on the left of that orange line.
Mm-hmm.
Yep. Okay. And then with cataract surgery?
That would be in quadrant 4.
In quadrant 4.
It's the least expensive and it's the most effective, or the same level effective.
Right. Okay. Yep. No, that's fair. Yeah. Anybody any other thoughts on that? Anybody disagree?
Well, on our side, so we went for basically that was on the more expensive side, given we were just comparing it on a use by use case. So basically the eye stent is like a single outflow, so it's more expensive for that payer, whereas our view is that the drops were basically it's just not the same payer who's looking at it. So it was on the more expensive side, and then it would be sort of on the one so more effective quadrant, but sort of towards the middle, given like the effectiveness was not necessarily very strong, but the cost effectiveness was there. So that was sort of our rationale as a team.
Yeah, you've raised a couple of really interesting points which I want to touch on. So and one is it goes to who's impacted. That's why I like this case, because there's 2 parts to it. So yeah, and what quadrant exactly with the cataract surgery we could argue with, but I think we're agreed that it's cost effective, so therefore it's on the right-hand side of the line. And without cataract surgery, the conclusion is from Health Quality Ontario is it's on the left side of the line. So not cost effective versus cost effective. Now, Marc-Antoine, you raised a really interesting point, which is, well, wait a second, we've got different payers we're talking about here, and you're quite right. So glaucoma drops are paid, it's a drug, and it's paid for by the Ontario Public Drugs Program. They are a part of government, and they pay for drugs, and that's their budget, and away they go. You're bringing a solution to the table which impacts that budget, but it's not paid for from that budget. It's paid for from the hospital budget or from other budgets. It gets very, very complicated because now you're trying to convince one arm of government to spend more money. It's flat out more money so that another arm of government can save money. So in totality, that makes sense, no problem, but it can be a complicating factor. So this is an important piece when it comes to knowing your impact. If you're increasing somebody's budget, you're having a significant impact. And government is not a monolith. I guess that's the point. Different parts of government, different budgets being managed. You're saving this guy money and you're costing this guy over here. So this guy over here maybe isn't happy. This guy over here is happy. So those are dynamics that you need to think about with your medical device. Make sense? Any questions on the cost-effective aspect? Yes?
No, I have a question in terms of when discussing different budgets. So how much do governments value the argument of cost savings across budgets? When you're talking about not saving them costs within the drug budget, for example, but from the hospital budget?
It's a very, there's not a definitive answer, but I will tell you it's a common argument for companies to make. If you just pay for this drug or this medical device, we're going to save you so much money over here with length of hospital stays, for example. And so this is where the value offering, that first pillar, that's an important part of it. So your value offering is, okay, we're going to give this to patients, and you're going to pay lots of money, but boy, down the road, look at how much money you're going to save with hospital readmissions or that kind of thing. So that's a great argument, but then you go to the strength of the data and they say, okay, well, can you show me the proof? Well, it's just logical. If we do this, we're going to do this. We need some data behind it. So that's where companies can get hung up, where they make that value offering argument. It makes perfect sense, except that the payers will say, okay, makes perfect sense. Now show me the data, and you don't have the data. Does that answer your question? Yeah.
Yeah.
So let's maybe just jump to another group and we'll talk a bit about stakeholders. So that was the kind of high level list that I gave you. But who wants to jump in here and talk about the different stakeholders they identified?
Mark, I can jump in first.
Okay, good. Thank you.
Yeah, so the stakeholders is going to be patients, hospitals, clinics, surgeons, distributors, and as you suggested, patient groups, also in the clinic side. Or anybody I feel like who is going to impact, maybe in the hospital there are pharmacy who sell these ones, and from the distributor, it will be they will be the stakeholders.
Okay, that's a good list. Anybody else? Anything that's missing from that list?
I don't know if I want. This is Elise, so I don't know if she mentioned or not, but some of the business department, they always like having a big link about to approve the products in the hospital or any medical center.
Sorry, a big link to approve?
To approve because of the budget, because of yeah, especially the budget.
Yes. So then who is a stakeholder in those circumstances?
They will be added to them with patient with the business decision makers, with distributors, with if it is like related to doctors, it's gonna be doctors. If it is related to nurses, more than doctors, it's gonna be nurses first. It depends on levels. So who are like the most priority to be involved in? Some of them nurses first, some of them like specialists in the hospital. So we have to, yeah, I think focusing about who is using this product in order to be stakeholders.
Yes. Yeah, you mentioned nurses, and they, I'm not so much sure that they would be significant in this case, although they are certainly a stakeholder because they're involved in the surgery. But in some circumstances,
yeah, I hope
nurses
so.
can be-
Sorry. I hope so, but I found it always like doctors, but also nurses in surgery rooms. They use those products and they know which is good, which is not good. And until now, they just focusing about surgeons, and that's good enough. But also, I don't know. Everywhere I'm from Yemen, I live in Canada now, but I found it like a little like strange that we always don't let nurses or practitioners in surgeries be involved in those products, and that for me as a biomedical engineer is so strange.
Well, you're right, and particularly in some aspects of cardiac surgery, as well as other therapeutic areas, nurses can be hugely important in influencing, and in some cases, it's the nurses who are using the medical device, so they become extremely important. So yes, and nurses could be. Anybody else on the list that might be missing?
I don't know if she mentioned the Ontario Health or Institute National Excellence.
There are institutions like that. You're talking about the Research Institute, yeah, potentially, and Ontario Health potentially. There are certainly, I think I'll pick up on that theme and say there are different. Again, you don't make the mistake that government is a monolith, that government is one piece or one stakeholder. There can be multiple stakeholders within what we would call government. And multiple, there might be different messages. And I think the example that I gave earlier about the bureaucracy versus the politicians, they respond very differently to messaging. So the politicians are, of course, very sensitive to the public and the media. The bureaucracy is more sensitive to alignment with government priorities and the implementation and so on. So you will often see this where somebody has a rare disease or maybe cancer, and the drug to cure that or treat that is not covered, and so they end up on the front page. That's political advocacy at its most brutal, at its most in your face. And politicians will pay attention to it. And I've seen drugs and medical devices get listed because it ends up on the front page of the paper. If it is not an issue where, if it's, what would be an example of an issue? If it's a less publicly sensitive issue, like eye stents, for example, I don't think you'd see this on the front page of the paper because there's pretty good medications out there. I mean, drops work, and they've been working for years. So it'd be pretty hard to get political involvement here, but the bureaucracy might be interested in some of the cost savings, and how we manage those cost savings from the drug budget over here to the hospital budget over there. That's a implementation. That's a bureaucratic play and discussion. Yeah, so that's an important point. We're closing in on the end of the session. So yeah, you nailed the stakeholders. So the next stage of developing a plan would be to say, okay, doctors, okay, what is our messaging, or distributors? It was mentioned, so MedBuy and Health Pro. Hospitals, patients, what are our messages for those individuals, and what do we want them to do? And are they willing to do it? So that's a pretty high level overview of the stakeholder, but that's you guys get the idea. You identify the stakeholders, you establish the messaging, and there's also ways of, and I go through this in greater detail in the course, of positioning the stakeholders in terms of their impact, their willingness to help, their willingness to change their mind, where they're positioning themselves with respect to the medical device. Are they positive on it, negative on it? So there's all kinds of other dynamics when it comes to that stakeholder mapping. Very important part of reimbursement. Okay, so other questions before we close?
How do you rectify investors like your VCs and everything for those companies, for iStent or that filtration surgery product? Like, how do they fit into this?
They wouldn't really fit in with respect to achieving reimbursement unless there is somebody, an investor who has some influence. So yeah, I'm trying to think of an example where an investor group might be an important stakeholder. I mean, they're certainly impacted by they would be impacted by the success of the reimbursement. So from that sense, they are a stakeholder. But part of the stakeholder mapping process is positioning them on a map to say, okay, they're a very important stakeholder. Where's their influence? So their influence is going to be on the low side. Conversely, if there's an ophthalmology doctors, eye surgeons of what do they call it? Ontario eye surgeons of Ontario. There is a group of eye surgeons, so they're going to be an interesting group, and they will be a stakeholder with more influence. So once you do your mapping, you can determine, okay, we need to spend some time with the eye surgeons of Ontario. We don't need to spend much time with the investors.
Okay, thank you.
So yes, they're a stakeholder, but probably less influential, and therefore less part of your plan. Any other questions? Well, guys, it's been an absolute pleasure. If you want to reach out on LinkedIn and continue the conversation, I'm happy to do so. And I hope that was helpful, and really enjoyed the discussion.